Hi, I'm Maggie Virus, and this is Chapter 6, the Urinary System. About body fluids and their compartments. The human body is made up of 40 liters of water, and this is distributed between intracellular fluid and extracellular fluid compartments. The ICF makes up 2/3 of the total body water, whereas the ECF, which includes plasma and interstitial fluid, makes up for about 1/3 of the total body water. Other specialized ECFs include lymph, cerebrospinal fluid, synovial fluid, and gastrointestinal secretions. These are typically grouped with interstitial fluids due to their similar composition. Body fluids consist of solutes dissolved in water, and these can be electrolytes or non-electrolytes, but each play roles in fluid balance and cellular function. Fluid movement along compartments. Water moves freely between fluid compartments because of the osmotic gradient, but solute movement is more restricted, and this is based on membrane permeability, charge, and size. Electrolytes create stronger osmotic gradients than non-electrolytes due to their ionic dissociation. The distribution of ions differs between intracellular fluids and extracellular fluids. Sodium is the main cation in extracellular fluids, while potassium is in intracellular. These are maintained by ATP-dependent sodium-potassium pumps. Exchanges between plasma and interstitial fluid occurs at capillaries, and this is driven by hydrostatic and osmotic pressures. The lymphatic vessels then return leaked fluid from interstitial fluids to plasma. Exchanges between IF and ICF occurs across the plasma membranes and involves selective transport of ions and nutrients, whereas water moves bidirectionally through osmosis. Water intake averages about 2,500 milliliters per day, with sources including ingested liquids, food, and metabolic water produced during cellular respiration. Water output occurs through urine, sensible loss, sweat, feces, and insensible loss, which is lungs and skin, with the kidneys accounting for majority of water loss. The thirst mechanism is controlled by the hypothalamic thirst center, and this is activated by increased ECF osmolality, dry mouth, or low blood pressure and low blood volume. Osmoreceptors detect small changes in osmolality, and they prompt thirst, encouraging fluid intake before osmotic changes are fully resolved. Obligatory water loss, especially through urine, is unavoidable, and it reflects the need to excrete solutes like urea to ensure homeostasis. Antidiuretic hormone and water balance. ADH is produced by the hypothalamus and is released by the posterior pituitary, and it controls the amount of water that is reabsorbed in the renal collecting ducts. High ADH levels cause aquaporins to be inserted into the nephron membranes. This allows water reabsorption and production of concentrated urine. Low ADH levels result in fewer aquaporins and reduced water absorption, and the excretion of dilute urine, lowering body fluid volume. ADH is released primarily triggered by increased ECF osmolality, but significant drops in blood pressure or volume can stimulate its release through baroreceptors in the renin-angiotensin system. In extreme fluid loss, sweating, vomiting, hemorrhage, or high ADH levels also cause vasoconstriction. Disorders of water balance. Dehydration is one of the disorders that results from fluid loss through hemorrhages, burns, vomiting, and more, and symptoms include thirst, dry mouth, and decreased urine output. If water is lost faster than solutes, the cells can shrink as water moves out to the more concentrated ECF, and this can lead to hypovolemic shock. Edema is another condition, and it is the abnormal accumulation of IF fluid and is often due to increased capillary filtration or lymphatic blockage. Unlike hypotonic hydration, which is when too much water is consumed, Edema only in edema, only the eye swells and not the cells. Sodium. Concentration versus content. Sodium is the most abundant cation in the extracellular fluid and exerts significant osmotic pressure. Sodium concentration determines the osmolality of the ECF, and it influences neuron and muscle excitability, while sodium content determines the blood volume and blood pressure, and it influences the total ECF volume. The sodium content is controlled by hormones like aldosterone and ANP that regulate sodium reabsorption or excretion. ADH and thirst mechanisms regulate sodium concentration by adjusting the water intake and retention. Regulation pathways. Aldosterone is the key hormone regulating sodium reabsorption, especially in the distal nephron segments. The renin-angiotensin aldosterone system, or RAAS, is activated by low blood pressure, low NaCl, or sympathetic stimulation. Renin release from juxtaglomerular cells initiate angiotensin II production, which stimulates aldosterone release. Aldosterone increases sodium reabsorption and potassium secretion and water retention, and this boosts the blood volume and pressure. Without it, minimal sodium is reabsorbed beyond the DCT and leading to sodium and water loss. Atrial natriuretic peptide is released when atrial cells are stretched by high blood pressure or volume. The ANP promotes sodium and water excretion by inhibiting sodium reabsorption, ADH, renin, and aldosterone. Estrogens enhance NaCl reabsorption, and this leads to water retention, and progesterone has a mild diuretic effect. Glucocorticoids can mimic aldosterone at high levels, enhancing sodium retention and promotes edema. Cardiovascular baroreceptors help regulate sodium and water output by adjusting sympathetic tone to kidneys. Regulation on potassium balance. Potassium is vital for neuromuscular function and membrane potential stability. The distal convoluted tubule and collecting ducts fine-tune potassium balance primarily by secreting potassium. High plasma potassium concentration enhances secretion by principal cells. Low potassium suppresses secretion and promotes reabsorption. Aldosterone increases potassium secretion while promotes sodium reabsorption and responding directly to the elevated potassium levels. And although kidneys can reserve potassium, deficiency may occur without adequate dietary intake. Regulation of calcium and phosphate balance. About 99% of calcium is stored in the bones and calcium phosphate serving as a reservoir. The PTH increases plasma calcium by stimulating bone reabsorption and renal absorption. Blood pH and balance. The normal arterial blood pH is tightly regulated between 7.35 and 7.45. Most hydrogen ions originate from metabolic activities, including respiration and protein catabolism. If a blood pH is below the 7.35, this is acidosis, and acidosis depresses the central nervous system and can cause coma or death. A blood pH above 7.45 is considered alkalosis, and this is when alkalosis overexcites the nervous system and leads to muscle spasms or convulsion. Both of these affect enzyme function and metabolic stability. The body uses chemical buffers, respiration, and renal mechanisms to maintain pH balance. Respiratory acidosis occurs when carbon dioxide accumulates in the blood due to shallow breathing or lung diseases, lowering blood pH. Respiratory alkalosis is excessive carbon dioxide is exhaled, and this raises the blood pH. Metabolic acidosis and alkalosis. Metabolic acidosis results from an accumulation of non-volatile acids or a loss of bicarbonate ions, leading to low blood pH and bicarbonate levels. Common causes of metabolic acidosis include prolonged diarrhea, diabetic ketoacidosis, lactic acid buildup, and kidney failure. Metabolic alkalosis occurs when there is a loss of protons from vomiting or an excess intake of alkaline substances like antacids. Bicarbonate levels below 22 milliequivalents per liter suggests that metabolic acidosis levels above 26 milliequivalents per liter suggest alkalosis.